It's nice to come around and see some of you every once or every other year kind of thing. Uh, so I'm not going to bore you with a lot of concepts because when we talk about EMG, the physiologic aspects are quite dull. So I've tried to dumb it down a little bit just so that we can talk more about the few of the cases and just show the importance of electrophysiological evaluation or EMG. Really nothing to declare. So what I wanted to talk about is really just basic description of an EMG. EMG generally means that we do nerve conduction studies and then the needle examination. So I'll go briefly into details of those. And then the abnormalities that we typically see in peripheral neuropathic pain. So EMG has more indication than just looking at the neuropathic pain aspect, but we'll focus a little bit more on that and then discuss briefly as to what are the pitfalls and limitation of this technique in arriving at diagnosis. So I'm not going to go into a lot of details as to what neuropathic pain is, talking to this crowd especially. It is a pain that arises as a direct consequence of a lesion or disease affecting the somatosensory system. So neuropathic pain can be either central or peripheral, and our focus will be mostly to look at peripheral sources of pain and how it relates to the electrophysiological abnormalities. In Canada, 2 to 4% of our population suffers from the neuropathic pain, and one could argue that a lot of those patients could benefit from evaluation with an EMG in arriving at the diagnosis. So pain itself has its peripheral pathway and central pathway. Peripherally, you have the sensory nerve endings, sensory nerves going to the dorsal root ganglion, then to spinal cord and crossing over to go to the contralateral thalamus and then to the cortex. But our focus would be really from below the spinal cord level. So typically, what our test would be for this topic today is the peripheral nerves, and EMG itself is designed to look at the large myelinated fibers. It does not study the small fibers. So in large fibers, you have the motor coming from the anterior horn cells, and then you have peripherally, sensory-wise, you have the large myelinated fibers that transmit proprioception, vibration, and pressure, as well as touch. The small and unmyelinated fibers are not well studied with EMG, and so that's one of the limitations itself. So when we look at the fiber, the myelinated fibers are the ones that are thicker, and they are bigger in diameter. And so when we are studying with the nerve conduction studies, the pain fibers are not really, we are not able to study with the EMG. There are other modalities which, unfortunately, because they're very time consuming and there has not been any interest from Canadian institutions or governmental standpoint to really fund those. Those are not done. They're mostly done in Europe, where they're looking at more of a somatosensory testing. But EMG is our main physiological or neurophysiological tool. So when we look at the larger fibers for touch, typically rule or finger, for vibration sensation, tuning fork at 128 hertz. Unfortunately, majority of the tuning forks nowadays are not 128. When we order it from web, or even if you go to the store here, they are not. I've been doing it, and I time it every time I do vibration, and every patient I see. And now we order it on from wherever they order in the hospital, and half of them are actually higher than 128 hertz. But that's the ideal hertz for the vibration sense testing, and that's looking at the large fibers. And then, with pinprick, we look at the sharp pain, and then temperature is typically we use the tuning fork, assuming that that's colder than 20 degrees. But if you are doing studies, or if you are doing a formal proper testing, anything that's going to test cold temperature should be 20 degrees or less, and warm would be 40 or more. So when we see patients, I don't know if I got into that. They can present to you with paresthesias, hyposthesias, or weakness of the extremities. So clinically, what you want to define is obviously history-wise that it fits with the neuropathic pain problem, and then you do the examination, look for of any sensory deficits that are definable, whether they are mononeuropathy, a radicular pattern, or a polyneuropathy, or central or peripheral in origin. So that's the goal of your clinical assessment, because EMG is really your extension of clinical examination. So if you feel that the signs and symptoms are more suggestive of a central disease process, EMG is not the test you want to order. You want to define on clinical grounds that this is a peripheral neuropathic source, and in it then you look at whether the weakness that is due to neuropathic, myopathic source, and then EMG can help differentiate between the two. If it is a pure motor syndrome, then your differential will be a little bit less, where you can look at possibility of motor neuron disease or myopathy or neuromuscular junction disease. Again, EMG can help you differentiate between those diagnoses, because that would be probably one of your best to establish a diagnosis if you're dealing with a junctional disease like myasthenia gravis or Lambert-Eaton syndrome or motor neuron disease. But for neuropathic, you can, on examination, look at what are the sensory deficits, what are the motor deficits, and then whether your clinical picture is suggestive of a radiculopathy, a plexopathy, or a mononeuropathy, and EMG will help you with confirmation of that diagnosis. When we look at, now my kids have actually stopped helping me making slides. So you can see that this is I picked up from an article. There are, instead of myopathy, it's saying myelopathy and stuff like that. So there are some mistakes. When we look at the peripheral axis, you can see that the motor neuron disease, or ALS, would be affecting within the spinal cord. The second structure that you can see here is the nerve root. If there's pathology of nerve root, we look at calling radical. I prepared it. I thought I'll have like fellows and stuff here so I can bug them. And then if it is affecting post-dorsal root ganglion, it could be plexopathy, mononeuropathy, and then you can have neuromuscular junction disease or the myopathy. So it will help you determine where the problem is arising from. And so the goal of an electrophysiological evaluation is really to see where the problem is, how severe is it, and then from the where standpoint, is it affecting the muscle, is it affecting the neuromuscular junction, is it coming from peripheral nerves, if it is coming from an individual nerve, or is it fitting with the anterior horn cells. So really the EMG is your extension of physical examination. It basically quantitates the pathology that's leading to sensory or motor deficits. So it is helpful in determining where the problem is, what type of problem it is. So in peripheral neuropathic processes. We worry about axonal damage or demyelinating pathology. So it will help us with that. Now, we are using a lot of ultrasounds nowadays. And ultrasounds, unfortunately, does not help you with that process. Whether there's axonal involvement or not, whether this is a purely demyelinating. And it does not really tell you about the chronicity that much, unless you have some subtle changes in the nerve, or if you see things in the muscle, you may guess, but with EMG we get exact determination. Then it also tells us how bad the problem is, how severe it is, and it gives us insight into the duration of problem. So if you have, if you cut a nerve and you do a needle examination, first few weeks we don't get any changes on the needle examination. Then the whole needle part is actually, it is dependent upon the maturity of nerve and muscle. So typically, if the process has been there for several months, say more than 3 to 6 months, there are certain changes we'll expect. If the problem of reinnervation occurred more than a year, we can tell that. Or if the disease process occurred within the last 12 weeks or so, we can get that idea from EMG, which the other tests may not give you. And then prognostic, say if you don't get any response and if there is no surviving exons, we are able to determine it and then give us idea about prognostication. So what is EMG? So EMG has nerve conduction studies part where we look at the sensory and the motor nerves. What we do is we have anatomic landmarks where we put the electrodes. So the electrodes are usually, you have the active and a reference electrode, and then we stimulate the nerve. Now when we stimulate, it has 2 prongs. One is which buffers the electricity, and the other one stimulates it. So typically, say if you have the median nerve you're stimulating, so anatomically where it is, we measure the distance. Now for sensory nerve, we record it either over a pure sensory nerve or a mixed nerve that carries the sensory and motor fibers. But we simulate typically where we have pure sensory fibers. So if you're going to do sensory median, do not stimulate the nerve when it's all mixed. So typically stimulation or recording is done over the finger where the sensory fibers are isolated from the part of the nerve. When we stimulate and record from the nerve, it's called compound nerve action potential. And we stimulate the sensory fiber, record from the sensory fiber, and do it over the mixed or sensory nerve. That sensory nerve action potential. For motor nerve conduction studies, we stimulate over and record over the muscle. So typically, it's all about looking at few things that determine how fast the message is traveling, and also what is the size of the message that's being propagated. So in case of the motor nerves, the stimulation is of the peripheral nerve and recording is from the muscle innervated by that nerve. And sensory is, as I mentioned, we do it over the sensory fibers and stimulate there. So the few terms you may hear in the reports, one is the distal latency. So that's the duration from initial stimulation to the onset of the action potential. So that's distal latency. Amplitude is the deflection, so the negative peak that you will see. And we measure it by either from the baseline to the peak or peak to peak. So we have normals for both for each age group, and then when we are reporting, we are also coding whether it's normal or abnormal. Then the duration of the for compound muscle action potential or motor nerve from the initial deflection to return to the baseline is the total duration of the compound muscle action potential, and then the negative peak has its own duration for us because they help us determine whether the primary process is demyelinating or not. And then we look at the conduction velocities. So conduction velocities are determined by the distance over time that it takes. So when we are studying the sensory nerves, we are stimulating the nerve part. There is no junction, there's no delay, and we are recording over the nerve or the other way around. So we know the distance, and the duration will determine what the conduction velocity is. So usually we don't need to go to spots. We usually stimulate the nerve distally at a determined distance, and that helps us with the conduction velocity. So the common nerves that we study are the sural, ulnar, and median, and then you study less commonly the radial, superficial peroneal, saphenous, and others. So what's important about sensory nerve conductions is that when there is a pathology that is distal to the dorsal root ganglion, then the sensory nerve action potential may be affected. So if you have a radiculopathy, it's a preganglionic process, the sensory nerve conduction studies are normal because the cell is sitting in the dorsal root ganglion and there is no damage to it. But whenever we have loss of sensory nerve action potentials, then we're dealing with either a plexopathy, a mononeuropathy, or otherwise we should have it preserved. So when a nerve is cut, the sensory nerve action potential may still be preserved for 7 to 10 days. So sometimes we get a referral from a surgeon saying, EMG, because yesterday we did the hip replacement and now there's foot drop. And EMG is not very helpful. It can be in some situations, but not so much in that specific scenario, and I'll go over it. For motor nerves, we have to stimulate the nerve twice. For motor nerve, because there is a neuromuscular junction in the middle, so the action potential goes and it releases the acetylcholine at the junction, and then the muscle contracts. So we cannot determine the conduction velocity on that basis. Therefore, we have to stimulate the nerve in a proximal segment, because if I'm stimulating the nerve, say median nerve here, and recording there, so that's the distal latency, this distance. Now we have determined, say this is 3.4 seconds. Then we stimulate the nerve here at 7.4 seconds, as an example. So now what we do is we subtract this segment out. So now we have the time it took from here to there, but we've subtracted this one, and this will determine distance over time as a conduction velocity. Then we do a bit more specialized testing. So one of them is F wave and other is H reflex. F wave is where we stimulate the nerve antidromically for motor nerve, because motor nerve is starting there going away, but we stimulate it so the message goes all the way back up, goes to the motor neuron cell, and then comes back along. So if there is a proximal segment where there is demyelination, or if there is something compressing the nerve, say close to nerve root or close to axilla, we don't study, because we usually study the distal segment of the nerves, that will be abnormal. H reflex is where you have, so FA, we typically see abnormalities if we're dealing with, say, demyelinating neuropathy like CIDP, GBS or AIDP. It could be also affected in radiculopathy because of the proximal segment. The H reflex, on the other hand, is like a deep tendon reflex. So what we typically do, it is commonly used for the S1 radiculopathy. So we stimulate the tibial nerve in the popliteal fossa, and so the sensory arm goes up, and then we record down at the soleus muscle. So that determines the sensory arm coming back the motor arm. And that again can be absent, as mentioned, in S1 radiculopathy and pluxopathy, as well as in demyelinating neuropathies. Then the next part of the exam is really needle examination. So the needle EMG is typically now with different kind of needles we use. Until 1990s, we had reusable needles. So they were mostly concentric needles. Now we use monopolar needles. So monopolar needle is the one which is an active electrode, and then we have a surface reference, and then we have a ground. And it helps us with first confirming some of the things we've already seen on the nerve conduction studies, if there is axonal loss or if there is a demyelinating process, and then also the duration of the disease process. So what we see in needle examination is insertional activity. So when we put the needle in, there's usually a little bit of a deflection. If there is instability of the nerve and muscle junction, then that insertional activity is increased. If there is replacement of, say, muscle with fibrosis, insertional activity is reduced. Then we look for spontaneous activity. Now, spontaneous activity is based on firing of the muscle on its own. So if typically the -70 surface potential is determined by neuromuscular junction. When you don't have functional neuromuscular junction, then you have a action potential from the muscle fiber. It's going to go through a refractory period, and when the refractory period is over, it's going to fire again. So it fires very regularly. It comes from muscle fibers. So though that would be for fibrillation potentials and positive sharp waves that we commonly see. We can also see fasciculations, we can see myotonic abnormalities, and we can also see changes like myokymia. And they help us determine what could be the inciting force for pathology. Then we look at the configuration of the motor unit. So once we put it in, patient is completely relaxed, and then we look for abnormal insertional and spontaneous activity. And then we ask patient to activate a muscle volitionally. And then how the action potential looks helps us whether there is any pathology, whether that's a myopathic process, whether that's a neurogenic process. And then we look at recruitment of the fibers. So if I am picking this up, I am looking at generation of force by the muscles that are involved. And if it is creating, say, 2 ounces of force, it may take 10 units, as an example, to give me that 2 units. But what if I don't have 10 motor unit action potentials? So in that case, if I have, say, 5, because 5 are lost because of axonal loss from nerve injury, then those 5 have to fire double. So the firing rate of each unit is increased. So that's what we call reduced recruitment, because more units are not recruiting in to give you that. And then we look at maximum force, how many units are generate the maximum force by that muscle. And again, in a myopathic process and a neuropathic process, they look different. So typically, if we are looking at problem with the nerve versus normal. So normal individual, you have as we put the needle in, there's a little bit of artifact, and then it's quiet. In something where there's a neurogenic process of a lower motor neuron loss, then the insertional activity is increased. In upper motor neuron disease, say somebody has weakness from stroke or spinal cord injury, then it remains the same. In a non-inflammatory myopathy, the fibers are not breaking, it remains the same, but otherwise you will see other abnormalities. In polymyositis, where the fibers are, or myositis of any kind, it is increased. The other thing we look at spontaneous activity. Normally, once the needle is moved, it then becomes quiet, and spontaneously, because when we're testing them on rest, not moving the needle, it's flat. But when there is axonal loss, you'll see positive sharp waves or fibrillation potentials. And in, say, somebody has weakness from stroke, we see nothing. Myopathy, regular, we see nothing. Myotonia, we may or may not see myotonic discharges. And then fibrillation positive sharp waves are happening in myositis as well. Then we look at the motor units. There is a size, the amplitude of it, and the duration of it, and how many times it takes turns. Those are the things we're looking for. And so in case that there was reinnervation, so reinnervation means you lost some axons going to that muscle, and then these friendly next door muscles have taken over, nerve fibers have taken over the muscle, and then the units become wider, they become bigger, and they have more phases. And that tells us there's some reinnervation happened. Now, if the amplitude is very small and it looks like this, and the recruitment is reduced, then we know that this reinnervation happened in the last few months only. But if it is big and it's not recruiting a whole lot, and if the size is bigger than, say, 2 millivolts or sometimes 5, 6, 7. So if you're dealing with something like 6 to 8 millivolts or 10 millivolts, then you're looking at things like polio in childhood that did it. There could be some slowly progressive neuropathy that might have done it. So that helps us to determine what the age of the process is. In a myopathic process, they don't only become polyphasic, they become sharp and small. And then similarly, we see same in the myositis. Interference pattern, again, is when we do maximum strength testing. And in neuropathic process, not too many units are firing. And so that, and in case of the myopathy, there are too many units firing. Because in a neurogenic part, just as I said, that say if you, out of 10 units, you're surviving with 5, 5 has to fire at a very high rate. There's no friends coming in. In a myopathic process, they are not generating enough strength, so a lot of them have to fire. So the interference pattern looks different. So I think we can just skip a little bit here. So it tells us about duration of the injury. So as I mentioned, for us to, say you have a nerve cut, you have a radial nerve cut or a sciatic nerve affected during surgery, the first change with the insertional activity, spontaneous activity, will take about 3 weeks or so to begin, 3 to 5 weeks. So typically by week 4, you will have abnormal spontaneous activity, you will have abnormal insertional activity. But it doesn't happen during the first 2 weeks. Now if somebody, say surgeon is insisting that, wrist drop happened, and you see the patient potentials already on day 2 of wrist drop, that means the problem actually happened a while back, not 2 days ago. Similarly, when we look at the reinnervation changes, the first few months, up to about 6 months, the potentials are relatively small. And beyond that, they start to get bigger and they become stable. And if they're stable and much bigger, then we know that something happened long time ago. So that's what it helps us with. So when do you consider ordering an EMG? So EMG would be preferred in diagnosing a mononeuropathy. Carpal tunnel syndrome is common. Foot drop from, say, peroneal mononeuropathy or ulnar, or you have multiple mononeuropathies, because that will determine what kind of disease process is leading to it. Radiculopathy, pluxopathies, brachial, lumbosacral, peripheral polyneuropathy, or cranial mononeuropathies. Now, cranial mononeuropathies, the common ones we use is really the 5th and 7th. So for 5th and 7th, we do the blink reflex. For 7th, say somebody has Bell's palsy, if the EMG is done during the first about 10 days, between a week and 10 days, it can help us in the long run with prognosis. If the amplitude is significantly reduced on the affected side by day, is poor. And then you can look at myopathy and other sources. So how much time do we have? So for polyneuropathy, it helps us whether this is an acute process, subacute process, or chronic. If it is axonal pathology or a demyelinating process, if it is pure sensory motor or sensory motor, and if it is large fiber. Because a small fiber, your clinical examination will be abnormal, and your diagnosis is established by skin biopsy to look at the concentration of the fibers in the piece of skin. So in axonal neuropathy, we looked at the distal latency, we looked at the conduction velocities, amplitude. The distal latency and conduction velocity would be normal. The amplitudes of the obtained potentials will be reduced, because that's determinant of how many axons are surviving. And then the F waves and the H reflexes would be normal. So what happens is, these are not like black and white. So typically, say you have a process that's leading to nerve loss of axons. We have the small, the medium size, the large size axons. Once we start losing, say, 70-80% of the fibers, then these myelinated or thick fibers are also lost. So then you start to see some slowing. But typically, this is amplitude would be the main factor determinant of loss of axons. When we look at demyelinating diseases, say, or even when we look at, say, ulnar mononeuropathy, a segmental demyelination. So there is slowing of the conduction velocity. There's, in case of a diffuse demyelination, there will be prolongation of the distal latencies. The H and F waves and H reflexes that are determining the big segment of the nerves will be also prolonged or absent. So that's determined, anything to do with the conduction velocity is affected in a demyelinating process. So needle EMG, generally, at least earlier on in a demyelinating disease, would be normal. It's just that it will not have enough number of units firing. So maybe interference pattern will be reduced, but you don't see other changes. But when you're losing axon, you will see active denervation, and you will see, depending on if it is a chronic process, reinnervation changes. So that helps us. So if you see the needle changes, and if you see reduction of amplitudes, then we're dealing with axonal process. And then you can go through what kind of axonal. There may be some variable. These are different type of neuropathies that once we determine that EMG is doing it, then you try right after these ones to see if you can determine what is leading to a polyneuropathy. Uh, so in a painful polyneuropathy, the common causes in Canada at least would be diabetes, um, alcohol-induced toxic neuropathy, acute, and the other ones are not that common. In my area where I'm working next to the cancer center, the neuropathies are generally acute. Most of them are axonal, coming from the chemotherapy. The vast majority of the neuropathies that I see are related to platinum drugs. And platinum drugs are pure sensory neuropathy inducing. They affect the dorsal root ganglions and neuropathy or neuronopathy. And their exam is a little bit different clinically. They do not sometimes follow the length-dependent sensory loss. Um, what I see commonly is that people with chemo-induced neuropathy frequently have carpal tunnel syndrome. So you will find someone, because somehow they love hydromorph content at the cancer center. And so you'll find someone on 36 milligrams of hydromorph because pain. And when you examine them, when you do the testing, they have carpal tunnel syndrome. That's the main symptom that's bothering them, giving them that much pain. And then you're left to deal with tapering them off gradually and all the struggles that you have. That's one population where still opioids are being liberally prescribed, unfortunately. But EMG helps me a lot because in case of, luckily we have the perineural hydrodissection treatment. It's not a long-term treatment. It provides relief for 4 to 6 months for most patients, and especially chemo patients. So I usually send them there. They're nice enough. They accommodate them soon. And they're comfortable, and then you can start working on tapering some of the medications down. But so neuropathy-wise, I thought we could maybe just talk a little bit as to what diabetes, which is the #1 cause of neuropathies in Canada, what it leads to. So diabetes can commonly is what we see here. Distal sensory autonomic or sensory motor. These are more common. Autonomic is whenever there's small fibers affected, there will be autonomic involvement. Then you can have acute neuropathies which are reversible. So pluxopathy, say diabetic hemorrhaphy, is not infrequent. You can also have neuropathy. So if I have to pick up majority of the people that we do testing for, at least in hospital, not in my clinic, it is for carpal tunnel syndrome. And I am always surprised as to how frequently, when we investigate why carpal tunnel happen, that you end up picking up BT so frequently, which was missed, which were not tested. So usually you want to screen them for it. So, but in carpal diabetic patients, mononeuropathies are more common than your average population, and then it predisposes you to other type of neuropathies. One thing I sometimes see where EMG is usually normal is either a treatment-induced neuropathy or insulin neuritis, that the old name. That's when you lose weight and you become straight, you really have good control of sugars, and then you're stuck with this very painful distal neuropathy. But it's reversible. It tends to get better within a year. So if you have somebody who has pure small fiber sensory deficits, preserved ankle jerks, and no motor involvement, vibration sensation is normal, position is normal, there is a chance, especially if it started after a strict control, that it will be reversible and will get better within the next few months, provided you keep the sugars in good level. So I'm actually, because we don't have a lot of time, I was thinking of maybe presenting a few cases to just highlight. So these are cases, I just added them on today in between my clinic. They are from my out of the hospital clinic. So these are the actual EMGs, and the reason I wanted to bring them up was to see what you expect. You can see that Joe sent me this patient, 62-year-old patient for left upper extremity pain and sensory symptoms. And we did the testing. So we did the motor nerve conduction studies. Oh, it's not even coming. How do I go? It's not in the, it's my, I just put a, it's not on that file. I need to put it up. Okay. So he had a work-related injury long time ago, and then was complaining of problems with numbness and tingling of the hands that will wake him up from, or with use, and also had some radicular symptoms. So we did the nerve conduction studies. So here, when I look at the numbers, they will be all mumbo jumbo to you guys, but that's what I wanted to actually, because EMG is one test that is so much dependent on what you look at and who's doing it. Because say if somebody has, to me, if I'm looking at L5 radiculopathy and I don't do peroneus longus, I can miss it. Because typically what we do is we do the needle examination of distal muscles. And if we see abnormality there, then we move upwards, right? So L5 I've been doing this for 20 years, EMG. I had 2 cases of L5 radiculopathy where peroneus was not affected. But almost every other patient had peroneus longus abnormal. So if you don't do it, then you're going to miss it. Similarly, I see frequently people where biceps and brachioradialis is commonly associated with C6. But I have cases where they are predominantly supplied by C5, and you have clinical picture of C6. And if you don't do pronator or flexor carpi radialis, you may miss it. So sometimes, depending on what the clinical picture is guiding you to, you have to guide your test accordingly to rule out a certain diagnosis concretely. So in this patient's case, the latencies we talked about, distal latencies, 4 is normal for carpal tunnel, for median nerve. It's more than 4, so these are prolonged. Amplitudes are normal at 5 or more, so they were normal. And conduction velocity is normal at 49 or more. Conduction velocity is normal. So the only thing we've seen that the distal segment of the nerve, motor nerve conduction studies are showing that there is prolongation. The ulnar nerve was normal. Again, conduction velocity is okay across the elbow. Amplitude is 6 for this nerve, normal. And then latency is less than 3.5. That's normal. So then we go to the sensory nerves. The amplitude should be 25 or more. It is reduced. The latency or conduction velocity should be around 50. It is slow. It's normal. So here we are seeing that there is a segment in this part here, because we stimulate the nerve, median record there. For sensory, we record from digit 2. Ulnar, we record from digit 5. And then motor, we do it here. So in this segment here, we are seeing that there is a segment of median nerve that is showing slowing. So that fits with the carpal tunnel syndrome. This distance difference should be more than 0.5. And so that's sensory involvement. So if it is purely sensory, then it's a mild neuropathy. When the motor is affected, then it's moderate because it's sensory motor. and then we do the neural examination, and if it is denervating, then it is severe carpal tunnel syndrome. So that's carpal tunnel. But interesting thing is we haven't done the needle exam. When we move to the needle exam, so these are the muscles. We talked about the insertional activity, and then the resting state, and then the volitional potentials. So we the deltoid, that was normal. Triceps is showing significant amount of active denervation, so that's axonal loss because you're seeing positive sharp and fibrillation potentials. And then it is showing smaller amplitudes, increased duration, increased polyphagia, and reduced recruitment. So this is telling me that this happened within last few months, less than 5 to 6 months, and more than 4 or maybe even 8 to 12 weeks. So 2 to 4, 5 months is the duration of denervation. Biceps is normal. Pronator is showing me a little bit of old changes. That means that way back, whether it happened a year ago or longer. And then you have the latissimus dorsi that was affected, which is showing active denervation and then recent changes. All other muscles that are supplied by C6, C7 are normal. No active denervation. So then in that case, what do you do? So what you have determined when we talk about radiculopathy should be the muscle that are innervated by the same nerve root, but 2 different nerves. And so if you look at the nerve root, it's coming out, and then it gives off a dorsal branch, and then the ventral is going up into make the plexus. So if you have an entrapment at the nerve root level, then you should have the paraspinal muscles affected. So when I stuck the needle in the paraspinal muscles, it did show some active denervation. So although the other muscles supplied by the C7 nerve root were not affected, this is telling me that this is a recent problem likely within last 4 or 5 months, and this is fascicular, most likely. That's what I called it, that nerves are packed in fascicles. If something is pushing, so typically you have the fascicle of nerve, there's a membrane around it, next fascicle sits, they're all based on where it's going to end up. So if you have C7, you have different muscles coming from it. You have the sensory area coming from C7, but it will be packed on basis of the destination. So if something is pushing from, it may not take the whole nerve root. So in this case, there was a more problem with the lateral recess rather than at the neuroforamina. So it was giving it more of a fascicular pattern of involvement of the nerve. So this patient had carpal tunnel and C7 radiculopathy. So we can move on to another one. So this patient was seen in 2016, 67-year-old, comes in with weakness, foot drop, and actually symptoms suggestive of carpal tunnel, numbness and tingling of both feet. And so when we look at it, I know you guys are, because you're very effective, and neurologists, we are kind of all over the place, and you to the patient, and we're looking at where the problem is coming from and how and all that. So the reason I'm bringing these with multiple problems is that, it helps us determine, especially when a clinical picture is complex, when it may or may not be fitting with the imaging studies that you're looking at, it may be good to, like Joe sends me a fair bit of patients. And a lot of the times when you listen to the story, it looks like, oh, this could be surgery candidate. And you know how it is with surgery, with us. Like surgeon, you talk to them, they'll say, okay, no problem, this, that, and send the patient 4 years waiting period, 2 years. It's not uncommon. So where do we go? So yeah, you guys have also long wait. So Joe has been very nice to me that he has a little bit less weight from my patients, I think, or that's what it. So those are the patients where you want to make sure you're not sitting on a surgical case. If somebody's exuberantly losing axons, he needs surgery rather than pain. Or if you do pain control, he may just linger on a bit more because the original compressive pathology is still there. But what if he does not have a lot of axonal loss or a lot of changes on EMG? In that case, you want to maximize what you can offer interventionally. So in this case, you have the carpal tunnel, same thing. Latency was prolonged. Velocity is okay. We look at the difference between that. So that's the motor. Then we go to the lower extremity. You can see on the right side, we did not get any response from stimulation of the peroneal nerve at the ankle, below the fibular head or above the fibular head. And on the left side, the latency was a bit prolonged, but the amplitude is down and his temperature was a little bit low. That's the other thing. We make sure that temperature is in a certain range. In some cases, we're not able to keep it in. Because ideally, if you reduce the temperature, what happens is that the reason we get the conduction of a potential is because of opening of the sodium channels. So the positive goes into the cell. And in case of a cold extremity, the duration for which the sodium channels stay open is much longer. So one, you get a bigger response than you should normally. And two, the whole duration of the action potential is increased, so it's not propagating as fast, so it slows down. And so that's probably the reason here for slowing of the latency. The other possibility is that there could be some other factor which is affecting the velocity. Now, this patient is diabetic. So what happens in diabetic patients is that at nodes of Ranvier, because of significant hyperglycemia, the velocity slows down because it's saltatory conduction. And because of in uremia patients and in diabetic patients, we do tend to see a little bit of a slowing because of the metabolic effects on the nodes of Ranvier. But in any case, in this guy's case, we had the right peroneal that was absent, a bit of prolongation of the latencies, and sensory nerves again shows that bilaterally superficial peroneals were unobtainable. Pseudo was on the right was not present. Left was significantly reduced in amplitude. So we do know that there is axonal process at play, which is likely a neuropathy. And then we have a carpal tunnel syndrome on top. But the question was, why could we not get the responses from the peroneal nerve? And I needed that explanation. And so what examination, that's what we see. We see vastus medialis is good on the right. Tibialis anterior is showing active denervation. Peroneus longus is showing active denervation. These are chronic reinnervation changes. And then medial gastrocnemius is showing only minimal changes on the right. And then on the left side, we're seeing the same thing here without involvement of medial gastrocnemius muscle. And so this could be due to a radiculopathy. This could be a distal process from a neuropathy. So in that case, you need to go above knee and more proximal muscles to make sure it's not a radiculopathy. The muscles that are supplied by the L5 and S1 nerve roots. So once we go to the gluteus maximus, gluteus medius, shoulder, bicep femoris, they were all normal. So in this case, conclusion was that the patient has the neuropathy, and we needed to pursue further with the ultrasound to make sure that the peroneal nerve was not entrapped in its typical compression site. And that's what ended up happening. That patient was found to have peroneal mononeuropathy. And that can be actually, only Dr. Bain does the decompression peroneal. His weight for peroneal is over 12 months. And so to me, if I have to look at the perineural hydrodissection, the best response has been uh, with the foot drop from peroneal mononeuropathy. Usually 1 or 2 injections is good enough. So I have a lot of cases, but we will probably leave it here. I was trying to plea my case as to what can we offer, right? Ideally, what I hope for, if we have a comprehensive place, the EMGs for pain patients should be done at the pain clinic.
Done what?
Should be done at the pain clinic rather than, when they get a line elsewhere, because
So how would you suggest?
I don't know. I don't know. There are a lot of, it's because they're dependent on the technologists. Like in my office, I have 2 machines. So I've invested enough, but technologist is not available to me. She comes once a week. So I do once a week there, and the rest I do in the hospital. Because I also teach with the fellows and stuff, with the EMGs there, they can do conductions on themselves when they're training. But if we had something where, the challenge is that not everybody's geared towards the patients in pain clinic. And it's, like I've had many examples where patients were sent for certain things and comes back a normal study. And to me, because maybe I have a somebody else's evaluation in mind, and there's a very specific question that, does this patient has L5 or whatever, then I'm doing a little bit extra step to go.
EMG done by somebody like yourself, a neurologist, or an EMG done by physiatry. How?
A good electromyographer, and there are good ones around, should provide you with answer. Now, sometimes we are geared more towards neuropathies and motor neuron. Now, I've seen people, for me, even if there's a remotest chance of missing ALS, that's my last day on EMG. I don't want to do that. But when you go to a good physiatrist, sometimes they do miss those things. They may be very good at picking up, because a lot of the times what happens is we are lousy at MSK examination, lousy. And when you're dealing with mononeuropathies, how many times when you have a patient with carpal tunnel syndrome, you poke them there, they have epicondylitis. And sometimes what happens is epicondylitis is causing the dorsal cutaneous nerve of the forearm to be entrapped, right where the short of extensor carpio-radialis is. And 9 out of 10, or maybe 10 out of 10 neurologists will miss it. Physiatrists have better chance, the good ones, will better chance of having those things done.
So if we were to look at getting EMG in our clinic, what would we have to do?
You would have to actually get a technologist. Okay. That's the challenge. You don't have it every day running. You may have to a couple times a month or 3, depending on how many patients would be there. And the other thing is really because you can communicate, because sometimes I get a referral L4, 3 to 10 tons of things, right? When you talk to the patient, when you examine them, concern is not so much all those numbers, right? And so when you're communicating with each other, next time, it's a very concrete question, because here it is so wide, if you're not looking after a specific, you can miss it. So you need a tech. Machines are not that expensive. You can even get by with something like 10, 12,000. The ones in there, they are about 60,000, 40 to 60,000 in the hospital ones. But I have one that's about 15,000, one is 30, and I use the 15,000 one more because it's a lot more reliable. So it's really the tech part, and you have very good if I don't know if you can convince him. Ryan is a good electromyographer. It's just, he's so busy. But I think it could be a good role from perspective of, yeah.
Ryan did mention that. Maybe that's something we should be looking at within the clinic. But then, it's not just getting the equipment.
It's really.
Check, but he's not there all the time. Whether you could get somebody like yourself and him who's coming periodically.
Look, something like that would be something
shared.
worth looking into, because if it's shared responsibility is better, because you don't want to put it on one person. You don't want to be. So.
Appreciate you doing this.
Thank you. That's always good. That's why I can end up coming. So thanks.
Can you go back to your fiber size?
Mm-hmm.
And I noticed that you're going down the A fibers, they get smaller and smaller. Where at what point do you not detect?
We don't have.
I always thought it was the unmyelinated.
It's
fibers.
really the unmyelinated fibers. When you are doing a conduction, so we do it supramaximal stimulation. So basically, you're stimulating every single fiber in that nerve. Now, when you get the action potential, the initial deflection latency is determinant of your biggest fibers. So if I'm going fiber, velocity is close to 100. If I go to 5, it's 25. It's usually about 5 times of the size. And if you're going to 1 or 2 nanometer, it's 10 meters per second. So they are completely missed out. So our screens are isolating. They are only by 2 or 3 milliseconds per division. So we're not even in position to look at those ones. So usually below 5, definitely missed. But
The A deltas in there.
if you set up differently. No, sometimes we do what we call sympathetic skin responses. So what you do is you put the responses, the electrodes on all 4 limbs, and then you give them either a surprise or give a stimulus. I luck with surprise is better for me. So when you're expecting a autonomic neuropathy, then we look at that response. But at that time, the screen, each division is set up at 10 to 15 milliseconds compared to 2 milliseconds. So you can see them, but then you have to ignore the regular ones, because then you have to completely reset the machine because the filter setting is different and the sweep speed is different. So if we do it, we can potentially isolate it, because the yield is so low that is not done. And so everything we do here is based on reliability. So if you cannot reproduce it consistently, then it's not. And the other thing is we did not talk about the technical challenges. Now, what you're looking at here is microvolts for sensory potentials, millivolts for motor. And then if somebody is, say, not relaxed, muscles are still contracting. They are contributing to the electrical noise. And those microvolts, the tiny little ones, they will be missed. So the patient has to be relaxed. The stimulation we give, it has to be precise. We do not overstimulate. We do not understimulate. Sometimes I look at the waveform and I can say, come on, don't push it, because they've overstimulated it. So if you're close to a muscle, you will bypass the nerve and neuromuscular junction and directly stimulate the muscle itself. So then the numbers are not the right ones. So there are a lot of other things that we pay attention to, but it's a reproducibility issue. The only thing that we can get is really the sympathetic skin responses, which are the same size fibers.
It's really just the very largest fibers.
Yeah. And the other thing is really you want to do, whatever you do, you want to have it a reliable potential to do it.
Mark, thank you so much.
Thank you.
Really appreciate it.
Thanks.
Thank you. Please.